The broadcast is now starting. All attendees are in listen-only mode.
Hi, everyone. My name is Ryan Shimko. I am the practice consultant and deputy registrar with the College of Registered Psychiatric Nurses of Manitoba. We are pleased to have with us today Dr. Judy Boychuk Duchscher from Thompson Rivers University, and she's going to be facilitating a presentation on From Chaos to Complexity, New Nurses Experience the Workplace. So without further ado, I am going to introduce Judy and let her take over from here.
Thanks very much, Ryan. Okay, so I want to let you know a little bit of the challenge that we're working on this end. I've got some videos implanted in my presentation that I think you're seeing in front of you. Am I correct, you guys? They're seeing this in front of them? Yeah, they are? Okay, great. My apologies, I can't see you and you can't see me, so that's the challenges of webinar, but the advantage is that I understand there's 85 of you coming in from across the province, which is super exciting, and I'm just so pleased that you have such an interest in this topic. My own experience with this topic comes from about, at least 15 plus years now of doing research in the area of new nurse transition. And my initial 8 studies had generated a theory of transition and the stages of transition, as well as a theory and a model that I named transition shock. And I built on Marlene Kramer's work from the 1970s, where she established, and it wasn't, reality shock, culture shock, those are concepts that came prior to Marlene. But she looked at it in terms of the new nursing graduate. But what I found when I did my own research, my initial research was in my master's degree, was that the concept of reality shock didn't quite really fill out the experience that the graduates were having. And so the subsequent 8 studies that I did in that area filled this out quite nicely in my mind, and thus came my my own expression of this experience in the new nursing graduate. As of late, I've become quite interested in Marlene Kramer and I. Marlene Kramer's been doing this work, and I've been very privileged to join her in a couple of publications related to chaos and complexity. And the way that Marlene views it is with this idea of synchronicity, or complexity, synchronicity, multiplicity. So multiple complex events happening at the same time. That's essentially what it means. And I just finished an experience in Saskatchewan where I managed a 41-bed telemetry unit for about 3 years. And my experience, not only with the new grads, but the nurses in general, they're dealing with this all the time now. And I think that need to help not only the new graduates, but the senior nurses understand what is going on for a new nurse when they are in practice. And a big piece of this is a combination between their experience, which is my work, their performance and skill acquisition, which is Benner's work, and then another area which Patricia Ebright has done some work from the U.S. on this, and so I introduce a little bit of that to you today. And again, those are in the video. So what we're going to try to do, because we can't seem to make those videos work here at the moment, but I'm going to play them simultaneously on my computer. So if they look like they're lip syncing, it's because my computer is going at a slightly different intersection than the visual that you're seeing, but you'll get the general gist of it. So how do I move the slide forward on here for the participants? Okay, good. So I'm just assuming we're rolling along. So if there is anything, can we bring the chat up on here so I can see? I would really like you to write it in. And I've got Ari here who's going to keep a close eye on the chat so that if you have any questions or concerns or anything, I can see them and Ari can see them and she can point them out to me so that I can sort of stop and respond to your questions. And I hope that works for everyone. Can you test the sound? Uh-oh, I've got a question here.
That might be old if they can hear.
How do we know they can hear?
I would ask.
Okay, so hi everyone. We just want to know that you can hear me. And how do they respond?
And just type in the chat question spot if they can't hear you.
Yeah, if you can't hear me, just type in the chat question area. Because it looks like we had one person saying, can you test the sound? So just want to make sure you can all hear me. Okay, good. Thanks so much, Tracy. It's nice to hear one person say the audio is great, but you don't all have to say that. All 85 of you. But if it's working for Tracy, chances are it's working. So I'm just going to carry on. You know, the interesting thing about this experience is I think it's just so complex. And I do think I'm working, you know, with national groups as well as provincial groups and looking at all the recent literature on this topic. And it seems that we want to solve the issues of transition with a silver bullet, or however we use that term. I don't think there is a silver bullet. I think that it is a very complex process, and we're all kind of chipping away at different things. I do want you to be aware that my next endeavor, similar to Nursing the Future, which was intended to bring WIN and Nursing the Future, if those of you in the audience are familiar with those, we did conferences for like 9 years, and it was really, looks like she says here it's cutting in and out. The sound is cutting in and out, it says. Anyway, sorry, I'm just giving the feedback here. So the thing that I noticed about the WIN-NTF conference was that it was a platform for everyone to kind of come together and share what was going on so that we don't keep doing the same studies over and over again. And so my intent is to pull together a think tank on a national think tank on new graduate transition so that we can start to hammer out what is being done, what has been done, what don't we need to do anymore, and where are the holes in our research. And I do think, and innovation, I think one of those holes we're going to find is that we don't have enough information about this this aspect of practice that does make it so difficult, and it's the intersection between the experience of transition and the performance within transition. Because, you know, we're hiring new graduates and we are expecting that they will perform as new graduates, but in a practice setting that they will do what we need them to do. And it's up to us to make sure that we control those experiences so that they are reasonable and appropriate for that level of knowledge and experience. And sometimes I don't think we take into account that it's not just their heads that are transitioning, it's everything about that experience. And there's no question that they talk about it as one of the hardest things they've ever had to do was make this transition from being a student to being a professional practicing nurse. And when you think about, sorry, I don't know how it's transitioning. I need to move it forward. Just down here, is it? Yeah, there. You know, when you look at this visual, I'm sure that you feel what I feel, and that's this tremendous load emotionally, physically, intellectually on the nurse that is practicing, particularly in acute care right now. And the majority of new graduate nurses continue to transition into acute care. And so this is what they're experiencing, and they're often doing it as this nurse is doing it, you know, in a side hallway alone. And we don't want them to do that, because that's impacting on their ability to conceptualize and intellectualize what they're doing, make decisions that are honestly high level. Pretty much every area in acute care now is high acuity, because the level of comorbidity and the level of illness presentation of these patients is simply much higher. So this is not an unusual experience. My work, as you can see in this slide, set out to, well, it didn't set out to do that, but based on the evidence, it revealed a journey of transition that starts with, really, as you can see on the left, a focus on performance, a focus on doing. And within there, you know, are all the kind of developmental pieces that the graduates are trying to adjust to their environment, because it's different than when they were a student. They know they need to accommodate some of their practice experiences, because what they were taught is not necessarily the way that it's done. But an experienced nurse knows how to do those accommodations without compromising the quality of care. But a new graduate doesn't necessarily understand how that works. Along with that, of course, is this sense of concealment, the very need to make sure that you don't have access to the tumultuousness of their emotion and their intellect as they're going through these initial months of their practice, so that oftentimes they will conceal that from those around them, because they fear being judged and marginalized for not being the kinds of practitioners that you or we expect them to be. So I know you're all chuckling on that end. This particular slide always brings a bit of a chuckle, but it brings a bit of a, yeah, that's kind of true in particularly in acute care, where the level of risk with every decision that a practitioner makes is high. So the graduates are feeling this sense of, you know, I make the wrong decision, something really bad could happen. So I want you to just pause for a minute, and I don't know if you're around someone else, but I just want you to think about the differences that you see between these two depictions of a rose. Maybe you can type in the chat section some of the words that come to mind when you look at the differences between these two depictions of a rose. Fragmented, that's good. Oh, that's a good one. Boundaries are less defined, Chantel. That's very good. I'm going to pick up on the fragmented and the boundaries. Yeah, and segmented too, fragmented and almost fractured. Fragmented is almost an intentional, less emotional word. I think it was Lesha. Certainly fractured is, I had this beautiful idea of the way that my practice was going to be, and it looked like they had told me it was going to be. A rose is red, and it's got these green petals, and it looks pretty, and it smells pretty, and then I get to my rose, and I'm just basically slapping this thing together. The edges are not warm and inviting. They're kind of jagged. And we've got petals falling off. So I almost feel like something's fractured, and even the way that the rose is depicted, it's taped together. Somehow this sense that I'm just barely making it. And that is one of the many visual depictions the graduates shared with me over the years, and it's really very telling. Okay. So currently, Kathy Rush from the University of British Columbia in Okanagan, in Kelowna, is she and Robert Yankee, who's a librarian, have done some research, and I'm very privileged to have joined them in the analysis of this work. And these are kinds of things we are finding right now. And this is an analysis of new graduate transition programs over the last 20 years. Essentially, we know that at least, and I'd say that's a really low number, at least 65%. I'd say probably 80% of new graduates are entering practice in acute care. That doesn't mean they're not doing residential work, community work, public health work, but a large majority of the hours that they're getting are in acute care. And we know what acute care is like. The acuity, clinical complexity, level of chaos is significantly increased. We have staffing shortages. We have staff mixes, lots of generations with different ideas about the workplace and what that means, are working together or trying to work together. And we have a changing a demography which is influencing the attrition. So we have baby boomers who are going to be retiring pretty quickly. And as I mentioned, we're trying to cope with that. I think a lot of boomers are staying in the workplace, but they're not going to stay in the workplace forever. And what they can cope with and the way that they're dealing with the stress is different because they're older. So that feeds an exhaustion within the workplace. And it does seem, and I'm sure there's not too many people who would disagree, that the workplace needs are driving the expectations that we have of the new graduate. And this is problematic because it's not that the workplace needs mustn't be considered. They absolutely must. But I think the challenge is, a typical example is our procurement of new graduate nurses into very high acuity areas such as emergency. I'm just about to publish an article that, by virtue of the title, Proceed with Caution, Integrating New Graduates into an Emergency Department, should tell you that was not an overly optimistic outcome in that research. And the challenges, of course, are that the new graduate really requires stability, predictability, familiarity, and consistency. Those are all things you don't get in an emergency room. And it's really clear in my theoretical framework of new graduate transition that framed within a platform of success, the new graduate needs to be successful. You got to wonder whether or not we are pushing new graduates into areas where they're truly not intellectually, emotionally, developmentally prepared to practice. And many people would say that that's like giving a death penalty case to a brand new lawyer. And these are complex situations and practice environments where we need someone who has a lot of pattern recognition. And a good example is one of the situations in the emergency room during this study. A new graduate got he's like 50-year-old male come in and in abdominal pain. And he was given to this to this graduate, and the graduate, although to be fair, tried on several occasions to draw in senior practicing nurses and even physicians into the assessment and diagnosis and care of this patient. she was unsuccessful in doing so because the emergency room is a very busy place and people don't always have time. And oftentimes when she approached them, they said things to her like, do you need me now? Is this an emergency? Can this wait? It's a really hard thing to expect a brand new graduate to pick up subtle cues of an abdominal aortic aneurysm who is decompensating very slowly, very subtly, and pull a physician from a chest tube insertion that is, in the mind of the new graduate, far more essential. When in fact this patient ultimately deteriorated, was determined to be decompensating because of a vascular issue, taken to the angio suite and died on the table. So this graduate left practice and did return eventually. And I remember seeing this graduate, I don't know, it had to be 10 years, maybe longer, down the road. And I remember seeing her at a conference and just becoming overwhelmed with emotion because she had decided to come back into practice. And that was a very, very life-changing experience for her, and quite clearly not the outcome that the patient or family would have wanted. And we can never know what might have happened in that situation with an expert practitioner, but I do know that time was of the essence. So these are things that we need to be very aware of and very careful about. I have a really great colleague here in Manitoba by the name of Sarah Painter. And Sarah was a new graduate that I worked with when she was a student and president of the Canadian Nursing Students Association. And Sarah went into the emergency room early on, and she's offered me some really great insights that I'm sharing in this emergency room article as well. And again, very, very cautionary with regard to this practice. So that's all to say that the workplace needs need to be considered, but we absolutely need to put new graduates in a place that will develop and solidify their very new practice ideas. We can you remove this? I just want to make sure I'm thank you. Just want to see what else I want to comment on with regard to this slide. And again, these are the findings from all the research over the last 20 years. And we know that we're having trouble finding a fiscal solution to all the support that we need in practice. We need more nurses. We've got beds that don't have a room. But we're still caring for those patients. We've got increased acuity of the patients that we do have, and less nursing education than we've ever had before. I mean, that's the first thing that always goes is nursing education. And I tried to implement some foundational grassroots nursing education for my nursing staff in Saskatchewan, and although we did a little bit of it, it was like a stopgap measure. It wasn't something that they would consider on a long-term basis. And I don't know how we can think that nurses can keep up with this increasingly complex environment without additional ongoing practice education. So that's something we all need to be thinking about. So the research says that this is a stressful experience, that new graduates feel alone, often inadequate. Of course, they lack confidence and skill capability, not because they're not being educated properly, but because they're expected to do all of this sort of as they hit the ground. And I'm not sure that we don't need to think a little bit about how do we stage this? How do we scaffold these experiences so that they gain confidence and the increased complexity of the skill is unfolded over time? And it's exhausting. We're exhausted. You can just imagine if you're trying to deal with all those new things that it's even more exhausting. And this is not an experience that's isolated to Canada or the US. It's a global experience. And the other thing that I'm noticing is that the emphasis is on sort of theory, that if we can just teach them enough and if we can just give them some orientation time, then that will suffice. When in fact, they need to be immersed in practice in intentional, strategically unfolding experiences. And I know that sounds difficult, but it's possible. It is possible to alter the ranges and and scopes of experiences that the new graduates have with intent. Time embedded in practice is critical to progression. And so anyways, in terms of whether or not we're preparing, I just offer this and ask if we think that we are offering them experience and knowledge such that we progress them from orientation to integration. So come on in, let's teach you what it's like here, to development. Okay, now that you kind of have the basics, let's move you forward, let's take you deeper, to stabilization. We want to keep you here. What's that going to take to keep you here? And where are the cultures of support that we are providing? El Haddad, just a couple of years ago, put this out, and I really like the way that this particular researcher presented this information, talked really quite intelligently about what we call, or what this author has identified as, inhabiting disparate realities. So the reality that the new graduate is situated in is very different from the reality that A, they thought that they would see, and B, that they want to see when imbued with all the values that they hold around the nursing profession and their role as carers. So if you're interested, this is a really nice spin on practice readiness. I was recently on a plane. As you can see, it was just a little puddle jumper. And I was watching the pilots, because of course, the one pilot is your flight attendant, and how that works. And the flight attendant on the right was a female in the picture, and on the left, a male. I was absolutely mesmerized by their synergy and the way they worked together. And the person on the right is always the junior, and the person on the left is the captain, the senior captain. And I watched as they pressed all these buttons, and one never pressed the same button, but they all knew what buttons to press. And I watched their hands move. It was like a ballet. Their hands moved together, but never touching, because they knew exactly. And then someone would come and I'd just wait, and then I'd go under their arm. And they're flying a plane. It was just fabulous to watch, but it did serve to me as an example of the importance of all of us working together, and how when that happens, you fly a plane. It's really amazing. But a failure to understand the importance of working synergistically in this very complex environment is a plane crash waiting to happen, to use that metaphor. So Patricia Ebright has done some really interesting work with how do new nurses relative to senior nurses, and she's done a lot of her work by exploring senior nurses. How do they stack? How do they make decisions? And how do their decisions differ from the decisions that a new nurse is able to make? And this is where I come into the picture with my curiosity. So complexity is kind of a layering of problems and difficulty onto a situation. Chaos is when there's not necessarily an order of that complexity. And when you combine chaos with complexity, then that's often where errors start to happen, because the pattern recognition that's required isn't available. So a new practitioner who's looking for that kind of that steady, rootness, rhythmic presentation isn't going to find it. Whereas a more senior nurse can deal with all the layered problems because they've seen them before and they understand this often goes with that. But you throw in a few chaotic things, like you got a code over there and you got a patient who's screaming over here and a family who needs you over there, then they can almost think at two levels. So that's what Patricia Ebright is finding is not available in the new nursing graduate. Well, of course it's not. I wouldn't expect it to be. The challenge is that we often hold individuals responsible for the things that happen in the system. And in fact, performing, dealing with, and even identifying risky behavior is what we focus on. And again, we focus on the individual rather than helping the individual understand, how do you navigate a situation that isn't under control? How do you choose the priority and figure out a way to let go of whatever else is in that situation, or delegate that which is also a priority? So the complex work environments we're in, unfortunately, require us to deal with multiple complex and chaotic situations at the same time. So how do you do that? And so that's kind of what I want to talk a little bit about today. So it's not going to work for the audio. Okay, so I'm going to just try to play these two things at the same time. And okay, let's go. Bing.
I'm going to show you how to play the chaos game. It's very simple to play, but it has an extraordinary outcome. I begin with a big sheet of paper with 3 large points marked on it, labeled 1 and 2, 3 and 4,
Oh.
5 and 6. But I'll shut my eyes to do that, and now I'll just wiggle the pen around and dab a point. There it is. That's my starting point. So now what I do is I roll the die. I'm going to show you how to play the chaos game.
That's just not working. Okay, let's just stop that. And we're going to do that again. Sorry, everyone. I thought this would work a little bit more. This is not good. Frustrating. Okay, so I'm going to start again and hope that
I'm going to show you how to play the...
just a second. Okay, let's see if we can do it now. So I'm not sure why it's doing that. There. Okay, let's try that.
I'm going to show you how to play the chaos game. It's very simple to play, but it has an extraordinary outcome. I begin with a big sheet of paper with 3 large points marked on it, labeled 1 and 2, 3 and 4, 5 and 6. Now what I do is I choose a point at random on the sheet of paper. I'll shut my eyes to do that, and now I'll just wiggle the pen around and dab a point. There it is. That's my starting point. So now what I do is I roll the die, and it comes up with a 4. So what I do is I go halfway from my first point to the big point labeled 3 and 4. I'll mark that new point. That's my new point. I roll the die. This time it comes up with a 5. So I go halfway from my new point to the big dot marked 5 and 6. And I mark that point on the piece of paper. Now, of course, if you do this, you should use a ruler and do things accurately. You need to play it for about 24 hours or longer, and you need to play very fast. And now I roll the die. And this time it comes up with a 3, so I go halfway from my new point to the big dot marked 3, and that'll be about here. Now, of course, if you keep on doing this for a long time, what would you expect? You'd expect that you'd get an enormous mess of dots. But that's not what happens. Something very extraordinary and different happens.
Speed up the game on a computer, and this emerges. The chaos game has produced a complex and ordered geometrical structure.
So I don't know how many of you have time to play that game faster for 24 hours, but I thought that was just comical. But what is just so cool about that is that there is this order within that chaos. And if we can help nurses try to find that order in the chaos, that I think is how we can help them increasingly cope more effectively and be more efficient in these complex systems. So let's talk about complex adaptive systems and what they are. Well, first of all, they have a variability that evolves over time. The clinical units and hospitals that we work in are complex adaptive systems. Coordinated elements or agents, when taken together, constitute an organized whole, as that particular scientist was trying to demonstrate. And they're built from large numbers of subunits that have repeated interactions, and that interaction causes a collective behavior which feeds back into the individual parts and causes this organized chaos. So these systems are not stable, but that doesn't mean that there aren't patterns within them. They're just nonlinear. They're very flexible. They're continually evolving. And in some way, they're self-organizing. As we feed into them, we can alter the direction of those adaptive systems. Now, there's attractions for these systems. So, for example, things that we all are looking for, goals, shared visions, that pull us into or direct that system, that complex system in some way. And of course, the stronger the attractor, the more active the direction of that system. Now, disturbances that are close to the attractor, so if there's a system that depends highly on the nurse, for instance, which is the function of the unit. If there is something that happens in that system, it very much creates more chaos and more of an active system because that individual working within it depends on that particular resource. That attractor is very dependent on the circumstances. So when the system responds adaptively to a disturbance, it allows for more solutions to emerge. But if it responds misadaptively to a disturbance, it causes more chaos. So the chaos is, we need to control that chaos. So when you think about, and again, this is Kramer's work, the multiple patient simultaneity complexity. This is an example of the way a new graduate explains it. I've got 5 patients. Everybody needs something at the same time. It's life, if it's life and death, no problem. So they seem to be able to make those really high level when you really don't have 2 competing priorities. You got a clear priority, but that's not normal practice. Normal practice is you've got several clear priorities, and it's really hard to distinguish which one I should address and which one I should delegate. So obviously, as you can see in this last part, this is where the fear comes in, is that I've got to make equally demanding decisions and choices between patients. So when you look at this Sinophen complex system, you look at the bottom left, and this is the novice's practice, which tends to be chaotic. They act, they sense, and they respond. There's not as much analyzing or probing that's going on. They just see it. They respond innately and organically to whatever is going on based on, of course, what they've seen before, which is limited. And that is what I try to really speak about when I talk about the thinking of the newly graduated nurse, is they have a lot of information, but all that information doesn't necessarily allow them to make decisions because it's separate information. It's what Benner calls distinct pieces of information. So I've got another one, and this is Patricia Ebright, and this is very important that we understand. So I'm going to pull this one up here on my other computer. Oopsie. On my other computer and play the sound, and hopefully we can make it work. Okay, and where are you? I didn't think I was an overly coordinated person, but
well, when we identified the list of strategies that nurses use that sit on the right side of that framework next to the sharp end. One of the strategies we identified was something we called stacking. And every nurse knows what stacking is. They know what the stack is. It's that list of things you carry around in your head that you know you have to get finished before you leave, that you want to get finished before you leave, and it's based on what you believe are either needs of the unit, needs of your patients, the routines we have around here about how we deliver care and what we do. So as soon as the nurse comes on, probably while they're driving to work, they've got the list starting right in their head. Okay, I'm going to get there, I'm going to do this. And then when we looked at nurses and asked them about what they were thinking, it was very clear that they're carrying around this list in their head about what things need to be accomplished on the shift. But what we also learned is they may start out with a certain list, but it is always being added to, being shortened, elongated. It's being reprioritized, reorganized as the nurse goes throughout the shift and picks up different cues up from patients and their status, or from how the unit's running and what their responsibilities are to other people, that this list will constantly be reorganized based on what's going on at the time. Often reorganized because of some unpredictable thing. You had an empty bed, but you're getting an admit in 30 minutes. So reprioritizing of the list. And what we've discovered as we talk to experienced nurses and as we talk to novice nurses is the factors that affect their decision making around ordering that list and what they prioritize is a real discriminator based on how much experience they have. Experienced nurses, they may get a little hectic and frustrated with what's going on, but they rarely doubt what the order of the list should be, or how quickly they're going to get to something, or they have no qualms at all about all of a sudden picking something out of the list, pitching it and saying, that's just not going to get done today. But the issue with experienced nurses is they do that knowing all of the consequences, ramifications, and the fact that that's not going to compromise patient care. Novices, we learn, make their list. They don't as easily reprioritize the list. They have a little bit rougher time giving it up. Definitely reflects Patricia Benner's work in terms of being routinized, more linear in their decision making, wanting to just get tasks finished. So their list isn't as pliable. They can't mess with it as much. Well, the problem with that is certain cues and certain factors can arise during a shift that just for patient safety reasons, just for being able to accomplish the work down the road, that list needs to be shaken up a little bit. And that's what experience brings, how to manage and how to reprioritize that list. So when we see novices who graduate at the top of their class from nursing, but then get out into where they're practicing, into a complex adaptive system where they're needing to really be as adaptable as the things that are going around them, they'll take a year to 2 years before they'll tell you, at least this is what we're finding in the study we're doing now on stacking, before they've got it. And when they say they've got it, they don't mean that they're able to diagnose certain diseases, or they're able to put in a central line and take care of it, or some procedure. What they mean is they can manage the complexity and they can organize and prioritize their work and feel like they've given good care. They can stack very well. So we think that's an important strategy, and what we're trying to do now is build a knowledge base around what are the principles that experienced nurses use to reorder and prioritize that stack. If they throw out things, what are the principles they're using to say that's going to go and it doesn't matter? If they shoot something to the top of the list, what are the principles operating there that made that go to the top of the list? Because what we really believe is we can't make an experienced nurse by the time they finish nursing school, but we think we can teach them certain principles to at least consider and add to their decision making when they're deciding what to do next. Well, when we identified the list of...
So I guess the things I want to comment on there are pattern recognition is a very significant thing. And I think that we want to control things. So all of us, including Patricia, want to be able to circumvent these kinds of situations by doing something. And my personal opinion is that part of what's going to be uncovered here is nothing except an immersion in practice is going to give you a lot of these pieces. And as much as we want to speed up the process and we want to teach different strategies and give them different frameworks by which they can make their decisions, yes, do I think that we can add to this knowledge? Absolutely. And is this knowledge exploration moving in the right direction when it comes to new grads? Absolutely. But what we cannot change is the fact that the human condition and dealing with the dynamic nature of human illness and wellness in the moment, there is no solution for that. There is no fabrication, even simulation cannot do that. So I do think that as much as we can continue to work on these things and continue to infuse simulation, which I also think is one of the best ways to help new graduates and senior students deal with dynamic situations, is throw in a bunch of circumstances that keep changing and evolving, and put them off their game and destabilize their footing a little bit. That will help them with this kind of chaos. But I do think we need to respect practice. We need to respect the fact that it is in practice that all of those of us who are senior have learned all of these things. 10 minutes. Okay. So, I just wanted to, this is stuff that I've kind of infused along the way, but integration of theory within complex practice scenarios is a subtle element, because it's truly the intersection of the theory with the practice that teaches us how to manage the changing environment. But it also takes a lot of time for relationships between culture and organizational priorities and the economics that you're expected to respect in the workplace, along with the politics of, do I call the senior resident first or the junior resident? And that all takes time, and it takes mistake making and figuring that out again over time. That kind of collaboration is what is going to turn a wildfire into this controlled burn that I'm talking about. And I think that that's what we're going to be able to wish for now. This scenario in that we're dealing with in practice, that is not going to change. I don't think that we are going to see an answer to the chaos that we're experiencing right now. But what we do need to figure out is, how do we maintain quality practice within this kind of an environment, and how do you factor in the newness intellectually and socially and developmentally of a new nurse coming into this kind of an environment? How are we preparing them in terms of teaching, and how are we supporting them in terms of integration? I think this might be another. Oh, hold on there, chickie. Let's just move you back. Okay, I'll give you a little context here. What I'm wanting to show you here, I ran an organization called Nursing the Future for 15 years. And in that organization, I worked with hundreds of new nursing graduates from across the country, every province. And they developed their leadership skills, and they learned how to lead each other, which I hope to find a way to move it forward again. But I've got a few videos where they talk about leadership, and they talk about the things that they need as new nursing graduates. And I did want to share that with you. So I'm going to try and do the same coordination of the button pressing. Okay, let's, crackers, get you there. And
I also want.
Okay, let's see. All right.
And I also want to get to know senior nurses and nurses who are in positions that I so want to know how to get there. And I want to know, how do you get to be a success? How do you get to be... I so want to know how to get there. And I want to know, how do you get to be a success? How do you get to be in that position where people respect you and people look up to you and people are just wonder how you got there? And that's where I want to be.
You can see and you can hear the emotion in her voice. These young nurses that are coming out, they want to make a difference. They want to be respected by all of us as senior practitioners. They just feel overwhelmed a lot of times because they leave work feeling like they didn't do what they were supposed to do. And you do that a certain number of times, and that is what we call demoralization. So when you think about how do we prepare or integrate nurses into professional role transition, I guess the first thing is that we do have to think about how we prepare. And I'm suggesting that we have a little bit more of an intimate relationship between our healthcare practitioners or industry and our educational programs. And how we do that is, we can do that from a multi-pronged approach. You could have joint appointments. You could have a lot more of the nurses from practice coming in and teaching some of the courses, applying them to practice. We could start mentorship a whole lot earlier, where fourth-year students are mentored with nurses in the practice environment. Integration, again, how do we bring nurses, quote unquote, on board as new graduates? And how do we provide them with a balance between the real and the ideal? Because we all need that. I mean, if we sort of sent people into practice and said everything that you're doing in practice is perfectly okay, then we would see a really rapid decline in the standards and quality of our practice. But if we send them in saying none of that's acceptable, you got to elevate it to here, and they realize quite quickly that they have no power to elevate any of the practice standards that are going on, then that makes them feel as though they are failing on an ongoing basis. So how do we find a little balance between that? And I'm sure everyone in the audience here has great ideas on that. That's why I want to come together as a large group over the next few years. A synthesis. So how do we take the theory that we know and put that into practice? And how do we bring new nurses into this social environment supportively and not fighting one another, not sort of, mirroring a culture of oppression that we might be experiencing and leading us to not to support one another? That's definitely not going to help. I'm going to give this another try. And
I would compare it to being a parent. If I had a baby, I wouldn't just okay, sink or swim, let's go, I know you just came out, but good luck, it's a tough world out there. Can't you walk yet? Yeah, what's your problem? But really, that's honestly was my experience, was I don't feel like anyone was okay, I'm here to help you learn and be the best nurse you can be. It was it's today you're doing this and tomorrow you're going to be 20 more steps ahead and you should know what happened between those 20 steps.
So that is not everyone's experience, but if it's one person's experience, it's too many. So we do know that this is what new nursing graduates need in practice. And I want you to take that red and just pull it to the front, because success for a new nurse is really important to their ability to move forward through the stages of transition. But they do need consistency. And when I say that, I mean both personally and professionally. So if they don't have, say, they're going home to a very unpredictable environment, which is not necessarily healthy or safe, but if they're going to that at home, they need to go to a predictable environment at work. Hopefully they're all predictable, but definitely looking at their personal life and how it's influencing their professional life as they start practice is very important. So when you think about predictability and you think about floating, you realize that when I walk in, I have really no idea who I'm going to see, which unit I'm going to be on. Maybe there are units that I feel socially comfortable with and other units that I don't, and I can't predict that. Stability, this is where this idea of what kind of patient population are we putting new graduates with so that they can exercise and practice their skills in an environment that's safe for both them and their patients. And familiarity, how familiar are they with the roles and relationships, the knowledge that's required, the people, the social culture they'll be working within, and how often do they experience the same thing, the consistency of even patient presentation. That's how they learn, is they repeat experiences and behaviors over time. So this is just a real, overview of the different stages. And in the most recent 20-year literature review that we're doing, this crisis of confidence is coming out pretty loud and clear. At about 7 months, there is another crisis. And I think it's simply because the graduates have gotten to a point where they're relatively comfortable and everybody's starting to expect different things from them. And they are expecting different things from themselves. So that 6th month to 7th month to 8th month is causing them a lot of stress. So I actually was hoping that we'd have a little time to do this. I'm not sure that we do 2 minutes, but I do encourage you to think about strategies that might allow, and they can be anywhere from ensure that new graduate has someone to call on to make decisions, or a decision or a strategy to put them with an educator to talk about decision making and how do they establish an algorithm for their decisions in complex and chaotic situations. So I think I'm going to just stop there. And Ryan, you have a few words?
Hello, everyone. There were a few questions about some specific things centering around whether the presentation will be made available after. I can confirm that the 3 nursing colleges will have the presentation available after today, and we will have it posted to our website. So you can go to your respective nursing college's website, and that you can access the presentation after the fact. There were a few questions that came from the audience, and we were able to theme some of them. And I think one of the biggest ones, Judy, that we seem to emerge was the balance between the employer responsibility in terms of mentorship programs and preceptorship and all that versus the responsibility of the education programs to prepare competent and safe practicing nurses who are able to transition into the work environment. And so I was just wondering if you could comment on that.
Oh, that's like the $1 million question. How do we achieve that balance? I can say that it's not a balance that's A, easy to achieve, and and B, we're not there. But I see a couple of things going on. The first thing when I think about education is there are accreditation processes that, CASN, Canadian Association of Schools of Nursing, tries to be relatively contemporary and looking at the workplace environment, talking to managers and administrators about what is it that you're seeing in new graduates and what's missing, so that they can then take that back and say, we need to start changing the way that we educate our nurses in their undergraduate or in their certificate or in their diploma programs to better reflect what the workplace needs. The challenge I think I'm having is where the workplace is in its ability to continue the education of newly entering nurses and nurses as they move forward in their careers. There was no problem at all with bed meetings. I went to 1 million bed meetings, but I never went to one meeting where we talked about the nursing staff that we had on each of our units. Where are they in terms of their development? How can I, now you had individual meetings with each of your staff, which if you are a manager in the audience, you are lucky if you do those once every 2 years. And it's difficult. So how do we, as those individuals in practice, leaders in practice, how can you help the institutions generate a greater focus on coming together with the institutions that educate these practitioners to find a place, a kind of a sweet spot in the center where we can all take some responsibility and accountability? the difficulty is funding. It's always going to be funding. How do I get money to send my nurses to an education day once every 6 months? Or how do I have resources where I have a full-time educator instead of a half-time educator on my unit, and what do I focus on? So those kinds of supports within the workplace are essential. And I had a hard time doing that when I was a manager, so I know that managers around the country are having the same challenges. On the other side, I see a lot of work being done, and that's because, that's the environment I'm in right now. With respect to education, we are looking in BC, and again, I know that provinces around the country are going to have to start looking at how are we preparing our practitioners to be more ready, and the reason is that they're leaving the practice environments. We don't want them to leave the practice environments. And so people are looking to both education and industry to say, how can we do whatever we need to prepare them realistically for the practice environment, which is going to include SIM, which is going to include more practice ready assignments, so that when they're in their education, we're actually challenging them in a way that's going to reflect what they're going to be doing in practice, not sort of an idealized version. So we are working. I see steps working on that. And then I think on the industry side, we need to get together. There's lots of innovative things going on out there that a lot of us don't know about, that we need a way to share. So another strategy that I want to implement is a national repository for new nurse preparation, integration, transition, innovation, that you can go as a manager, an educator, or a practicing LPN, RPN, RN. You can go onto this repository and talk to the people that are innovating and say, maybe you could help us bring that to our institution. We need to start working together more. That is a very quick answer to a very, very complex question.
Thank you. I think we're running pretty short on time, and it looks like we've lost a fair bit of our audience. I'm sure everyone's going back to work. There was a comment that came out, and I think it was directed probably to the regions within Manitoba, that some coordination should occur in terms of the orientation that is provided to new graduates as they transition into the workplace. So just thought we'd put that out there as well, that that was one of the comments that came from our audience.
So thanks, everyone. I do encourage you to touch base with me through CRNM should you have any further questions or anything that you wanted to talk about, and wishing you all a good day.
Thank you.